Welcome everybody on Facebook. Thank you for joining us today. My name is Andrea Millers and I'm with Endogastric Solutions. We're here for our TIF Talk Tuesday, and I'm very excited to have our special guest, Dr. Andrew Ko. Welcome, Dr. Ko. Thank you for being here today.
Delighted to be here.
Thank you. So Dr. Andrew Ko is a gastroenterologist who's been practicing in the Orange County, California area since 1991. During that time, Dr. Ko's received many accolades in his field. His areas of specialty include esophageal and gastrointestinal disorders. He's also the founding member, or one of the founding members, of Pacific Endoscopy and Surgery Center in Fountain Valley, California. So again, welcome, Dr. Ko, and thank you for being here tonight. So as you all know, Facebook watchers, this is a live event, and at any time you'd like to ask Dr. Ko any questions, please feel free to comment section, and we will do our best to answer all of the questions that you have for him today. So we're going to go ahead and start. Dr. Ko, can you let's start off talking about GERD and acid reflux. Maybe give us a scientific explanation of what is GERD and what types of symptoms could a patient feel if they were suffering from GERD or acid reflux?
Sure, happy to answer that. The GERD is a very common disorder in the United States. It affects about a quarter of the population, which is about 80 million Americans. About half of them will see a doctor. About a quarter of them will require some kind of a long-term management. But the basic disorder of the GERD is really an anatomic problem. It's an anatomic disorder that involves the presence of hiatal hernia many times, in combination of a lax a muscle sphincter, they call lower esophageal sphincter. In combination, sometimes you may not have both. Sometimes you may have a problem with one or the other, or sometimes both. And the severity can vary quite a bit. So it's an anatomic disorder that fails to prevent a reflux or regurgitation of the stomach content into the esophagus. So as a result, the presenting symptom can vary from heartburn to chest pain, dysphagia or difficulty swallowing, coughing, hoarseness. It really depends on how quickly the gastric content regurgitate into the esophagus and up to how high it goes. It can change the presenting symptom.
Okay.
Yes.
Thank you. So what do you suggest for patients, initially before medical therapy or even, procedurals or surgery? What do you have your patients do to manage their GERD symptoms? What do you recommend?
Sure. In mild situations, the GERD can be managed without medications or without doing any extensive evaluation. It can be managed by a dietary modification, lifestyle changes, and the dietary modification may include avoiding spicy food, coffee, tea, chocolate, tomato sauce, fatty meal, not eating late at bedtime, overeating, wearing tight-fitting clothes. There's a different kind of either dietary changes or lifestyle modification can suffice. So if that's all that is needed, then you may not need to do anything further. But most of the times, it may not be enough.
Right. So we're getting some questions already for you. First off, people are saying good evening to you, Dr. Ko. So good evening. someone's asking, what is the success? Well, let's actually keep going, and then we'll talk about the success rate of the TIF procedure. So let's dive into that right now and talk a little bit more about what are available treatment options for GERD currently.
So traditionally, the treatment has been a medication. After lifestyle changes, dietary modification, if that is insufficient, then you go to medication, and you can go to so-called H2 blockers, which are mainly like Zantac or Pepcid. And a lot of times, if that may not be enough, then you go to a so-called proton pump inhibitor. Most common medication is Prolosec, over the counter, and there are variations of those medications as well, like pantoprazole, Nexium, Dexilen. They're designed to lower the level of acid in the stomach, so that even if you get regurgitation, you don't get damage from the regurgitation. So the medications are designed to protect the esophageal lining from acid damage, but it doesn't really fix the fundamental problem of regurgitation or reflux, namely the abnormal anatomy. So although the problem is in the anatomy, the medication treatment is to lower the acid. So there's a lot of misunderstanding that comes about because of that. That a lot of people think that the GERD is actually from too much acid, which is it's a misunderstanding. Is because of too much acid. Is the acid that's normally there going up in the wrong direction is a problem, and the medication, it tries to lower the acid level.
Right. So speaking of that, there's a lot of consumers that are starting to get more concerned of long-term effects of PPI use. And then there was recently a published paper about PPIs potentially increasing your chances of getting COVID. And as we know, during this time, a lot of people are nervous about that. Can you talk a little bit about that?
Sure, which is a very appropriate question to ask at this time of pandemic. There are long-term side effects of PPI, and if you count them, it goes to about 10 to 12 different long-term side effects. But the most recent one that's concerning in this time of pandemic is that there's a recent article that was published in the American College of Gastro journal that reports that there's about twice the risk of getting COVID when you're taking a PPI once a day. That risk goes up to four times the risk if you take double dose PPI. So it's a twice a day PPI increase the risk of COVID, which kind of makes sense because in a logical sense, because the acid is there to, one of the function of the acid in the stomach is to protect the system from foreign infection. And when you lower the acid level, there's a potential chance of infectious material passing through.
Right. Okay, thank you. What about long-term side effects of PPI use? Do you have any studies that show that there are long-term side effects of?
So I mentioned there are about 12 different kinds.
Oh, that's right. Sorry.
Yeah. So and I can list some of them. The most common one that we talk about are potential injury to kidney, magnesium level going too low, so hypomagnesemia. Sometimes you can get bacterial colitis related to so-called C. diff colitis. Osteoporosis is very common. There's some drug interaction with other medications, so particularly cardiac medications or blood thinner. There's some remote association with dementia, heart disease, or some other causes.
much. Appreciate that. Let's talk a little bit now about what are the different, after medical therapy, what are the different options, surgical options, if you will, and then, you can talk about the TIF procedure as well for treating Gerd.
Yeah, so this is to me is an exciting time to be in because I've been in the field of gastroenterology for almost 30 years, and during this time, the treatment for Gerd, it was essentially using PPI, and of course, if you talk to the surgeons in the past, they would say Nissen fundoplication was the way to go. So I remember going to many different medical conferences with the surgeons and the medical side fighting back and forth, which is better, and there was no clear answer. But the Nissen fundoplication has been the last resort therapy after you fail PPI. But not many people got referred to it because there were high rate of complications, up to 30% of dysphagia. People were not happy with the outcome, and they tend to get undone over time. So you may end up back on the PPI again, and it was very difficult to reoperate that surgery once it's done. So it was not a popular option, but it was used as a last resort. But when I say this is an exciting time now is because we're not fighting between the surgeons and the medical, the doctors. We're now collaborating instead when we treat this, because this development of TIF procedure, which is a minimally invasive operation done through oral approach, revising the muscle to make the normal physiology back to where it was, and has a very minimal potential complications. And so we're both excited, from medical doctor like myself, gastroenterologist, to a surgeon, and we can collaborate between two different fields and achieve an excellent outcome. So this is a very exciting time where we can now offer definitive a cure essentially for this chronic illness, so that you don't need to take these medications over long term.
Wonderful. Can you talk a little bit? I think when we talked earlier, you discussed a little bit about the collaboration, which is fantastic, between a surgeon and and you said the majority, if not almost 99% of your procedures with the one procedure was a straight TIF, meaning you collaborated with a surgeon to do a hiatal hernia repair as well as the TIF procedure, correct?
Right. Yeah.
So yeah, go ahead.
So before the Nissen fundoplication is where the surgeon would go in, close the diaphragm, and wrap the stomach around the esophagus, and that's the Nissen. So it's wrapping the esophagus 360 degree around the esophagus, and the problem was that was causing patients with dysphagia and bloating, gas bloating, and so forth. Satisfaction rate is very low. So what we're doing now is have a surgeon go in and close the diaphragm, but stop short of doing the wrap. So stopping at the point where he's just closing the diaphragm and coming out. And then the TIF part is where we go inside and doing the wrap part of the Nissen fundoplication, but done from internally, and at a 270 degree, and the kind of operation achieves the end result that's very close to being physiologic. And the outcome has been excellent, with very minimal to no side effects or the chance of dysphagia or bloating. So
we're going to start answering some questions, if you don't mind. We got a lot in here, so that have been popping up. So first question, does stress cause acid reflux?
It's an exacerbating factor. So, in the underlying anatomy is the hiatal hernia and lax sphincter. That's the underlying problem. But there are modifying causes that makes it worse, such as stress, overeating, and certain types of food.
How safe is it to come to the hospital right now for a procedure during this COVID times?
Yes, the most of hospitals follow the CDC guideline. They take extreme precautions to prevent infections, and they would stop doing procedures if you run out of this the PPE that's required to provide this kind of care. But so right now, at least in the area that I'm in, they have enough PPE to proceed with the elective procedures in a safe environment.
Fantastic. Are you also doing telehealth visits as well, Dr. Ko, or is that, or yeah, okay.
Yes.
Yeah, okay.
Yes. Yeah. Most office visits are done by telehealth.
Okay. Dr. Ko, what is the success rate of the TIF procedure and what are the complications post-surgery?
So the overall, the success rate has been estimated to be somewhere close to about 80%. Some say about 75, between 75 to 80% success rate. The complication rate, if you compare to Nissen, this is incredibly safer. Whereas the Nissen fundoplication, you can expect to get about 30% of dysphagia. But with the TIF, we hardly ever see dysphagia, is almost to zero. And the kind of complication we're talking about now, our typical complication we talk about doing endoscopy. So the chance of perforation, infection, bleeding are estimated to be about 1 in 1,000 each. So typically around 0.4%, so under 0.5%, which is quite comparable to something like endoscopy or colonoscopy.
Right, perfect. Another question, is it safe to keep taking my heartburn medicine during COVID?
Well, I wouldn't stop it right away. You're taking the medication for a reason. You may have a serious reflux disease, erosive esophagitis. So if you stop the medication, all that underlying problem will recur and you will end up getting all the erosive esophagitis again. So if you weigh the risk and benefits, although I mentioned there's an increased risk of COVID, it doesn't mean everyone will get it. So you have to weigh the risk and benefits in every case. But the reason you're on the medication is because you have underlying problem. So I would encourage you to talk to your doctor about it before you just stop.
Perfect. Another question, for a patient that is concerned about having a TIF performed, what can you share to set the right expectations both pre and post TIF, including recovery timeframe and diet modifications? So that's kind of post-op. What can they expect right after they have the TIF procedure as well?
Post-op recovery, the most difficult part is the diet, but immediately for few days, you may experience some chest discomfort just between the sternum and the stomach. There's a substernal area, some discomfort that might require some pain medication. Not all, some patients will. And sometimes you get this referred pain to the left shoulder. There's nothing wrong with the left shoulder. It's just the body's fooling you. We call it a referred pain. It might last for a few days. And then the next difficult part is a diet, which has to be very gradual. And you start with a liquid diet for a clear liquid for 3 days, then full liquid for 2 weeks, then soft diet for somewhere between 2 to 4 weeks, and then the regular diet. So almost everybody lose some weight, which come as a added benefit in a lot of situations. But the dietary measures is really the challenging thing that you have to be aware.
And I've heard another physician say that the reason that the importance of the diet is so they don't, let that work that you did creating that new valve. Right. Do you want to talk a little bit about that?
Yeah. So initially, we're manipulating that GE junction, gastroesophageal junction, and putting fasteners and manipulation. So it causes initial swelling, some edema. So that inflammation has to subside. So initially you'll get a thickening of that area. So things will have difficult time going through. So you're just buying time for that swelling to go down and the healing process to occur. So that's more of a physiologic process during any kind of surgery. It just happens to be in that difficult area where the food has to go through. So you have to go easy until all that swelling to go down. Then you should be able to go back to normal diet over about 4 to 6 weeks.
Thank you. Here's another question about post-op. Will the TIF limit me from working out and lifting weights?
So lifting weight is the another restriction during the recovery phase. So during that 4 to 6 weeks, we advise patients not to lift anything heavy, and there's a certain protocol how heavy you get within first a few weeks to be 5 pounds, and then you can gradually increase the weight to 20-25 pounds. But after about 2 to 4 months or so, I think you should be back to normal. Although I've heard that some surgeons, I've heard, will tell the patients not to lift anything over like 50 pounds for good.
Oh wow.
Now, I don't think there's been any studies on that, but that's just a personal anecdotal experience.
Okay, so another question, can a diabetic have the TIF procedure?
Yes, it can. You just have to be careful. Certain diabetics can develop something called gastroparesis, which is a slowing of the stomach that might delay the gastric food to empty out. So it may be an added complication. Not complication, is another added factor you have to consider before decision making.
Okay.
But it's not a contraindication.
Okay. Is the TIF procedure considered a major surgery?
Well, it would be considered minimally invasive surgery. So when we say minimally invasive surgery, I don't know what the definition is of major surgery is. I guess it depends on how you look at it. So it's a minimally invasive. It's an incisionless if it's done without the hernia repair, so you don't get any scar, and it's all done through the mouth. It's like having an endoscopy. So some people might consider that major, some people may not.
Yeah, it's a good point. Good point. Is there a purpose to doing a TIF without a hernia repair?
Yes. So I mentioned there are two components that contributes to reflux, but you may not necessarily have to have both. So some people have loose sphincter, that ineffectual, the sphincter that doesn't work without the hiatal hernia. So if you don't have a hiatal hernia, it's just a loose sphincter, that's when you really need just a straight TIF. You don't need the laparoscopy to close the diaphragm. So people can have reflux disease without hiatal hernia, and vice versa also. So sometimes you can have hiatal hernia and no reflux. So you have to individualize on every case, and you have to have a discussion.
Okay, thank you. So another question, can Barrett's esophagus, hiatal hernia, and acid reflux all three of those combined, be taken care of during the TIF procedure?
Well, Barrett's esophagus is a long-term issue. So you already have a change in the cells, the lining the esophagus. So that Barrett's esophagus part will not go away after hernia repair or TIF. So that would still need long-term surveillance. So what you're doing with the TIF, you're fixing the underlying physiology, the defect that promoted that Barrett's esophagus. You will still need a long-term surveillance. You're not, there's no fix for Barrett's esophagus. There's a fix for the underlying problem,
right?
Not the Barrett's esophagus itself. So it needs a long-term follow-up.
Right. Perfect. Another question just came up. I have symptoms similar to Gerd, but have not been diagnosed. What questions should I ask my doctor to get to the bottom of my issues, or what tests do I need to have done on me?
That is a loaded question. Some people have a lot of symptoms they think is related to Gerd when they don't. And sometimes you can have a significant Gerd and have very little or no symptom. So they don't necessarily correlate. So it's for the patients and the doctor together to figure it out, whether whatever the symptoms you're having is actually Gerd that warrants some kind of treatment and follow-up. And you can be fooled many times. So you use multiple modalities to clarify that. One could be endoscopy, one could be the pH measurement, we call Bravo capsule study. Sometimes it could be manometry, sometimes it could be upper GI series. So you have a different kind of testing that we can do in conjunction with the symptom to correlate whether that symptom is actually from the Gerd.
So do you suggest this patient potentially go and see their GI or get a referral to a GI as opposed to talking to their regular physician, their PCP?
I would definitely go see a GI doctor nearby.
Yeah, perfect. Okay, another question. What makes TIF better than Lynx? From Luke.
This would be a biased opinion. So, so Lynx is there, and I think I don't want to say anything bad about it, but there are a lot of surgeons who would like to do Lynx, and they prefer to do that. My bias is that Lynx involves a foreign body, it's a magnet, it's a metallic substance, metallic material that moves back and forth. Once it gets in there, that first, the number one disadvantage that I see is that you can't really get an MRI study. So, well, you could get an MRI study possibly, but it may just demagnetize the whole Lynx that's inside of you. Somebody actually played around with this big magnet after Lynx, and they just demagnetized the whole thing just by putting a magnet right on himself. Just prove the point. Then they have to take it out. So if you really need to do something like that, then you have to remove the device. Then you lose the whole effectiveness of it. What we're seeing more and more is a lot of long-term complication of Lynx. And if you talk to many different surgeons, there are many cases where they have to go in and take the Lynx out because it can erode into the lining of the mucosa. It can come out. There's a lot of potential complications. It has a much higher rate of dysphagia, the significant dysphagia rate, which is the whole reason why we're not doing Nissen fundoplication. It's probably not as bad as Nissen, but still significant. Okay. So I'm not a great fan of Lynx procedure myself for those reasons.
very much. So we talked a little bit about recovery. Let's talk a little bit about living GERD-free. You've done quite a few TIF procedures. You mentioned hiatal hernia, TIF related concomitant procedures or combined procedures. Do you have any success stories from patients that you've heard? Do they come back and do you have any stories about them coming back and not taking their PPIs anymore or feeling fantastic after? What do you generally hear from your patients after the TIF procedure?
What the problem I have is they are too happy they don't come back. So
I guess that's a good problem.
some of the patients that I've been following for years prior to having this TIF done, I've been seeing them for every 6 months or so. We need to do an endoscopy to reevaluate and so forth. Once they do this TIF procedure, say, I don't need you, doc.
Oh no.
So they don't come back because there's nothing come back to talk about. So I have a number of them. But the recent one, I felt very good about was, some of the unusual cases that I operated. One case, it was somebody with an idiopathic pulmonary fibrosis, and this is a lung disorder, and thinking is that some of the reflux that aspirated into the lung may be contributing to the fibrosis of the lung, and then they get very short of breath and get cough, they get sore throat all the time. So the patient has been suffering for a long time, and sure enough, when we do the evaluation, he had a lot of reflux. So after the concomitant TIF, the 3 months later, he went back to his pulmonary doctor. He had a pulmonary function test done, came back and said, I had 100% improvement on the pulmonary function test just 3 months out. So that was a great feeling to have. And now I feel great, doc, because I'm not coughing as much, and so that was exciting.
That is very exciting. Wow, that patient must be very, very happy for sure. Oh, that's wonderful. I did have one more question that I wanted to address that has come up. Rajesh is asking, could you please give us a ballpark figure on the costs of this procedure and what should we have covered with the insurers?
Well, that's an insurance question.
Right.
I'm not really familiar with. Every plan has a different coverage. They goes into copays and different rates of copays and deductibles, and each insurance companies have their own contract with hospitals. So there's no one set answer there. And I'm not sure what, if they don't have an insurance, what the cost is. To be honest, I don't really know the answer to that.
At your office, or you go into a TIF trained specialist, their office can look up the insurance and find out what gets covered and what not, right, Dr. Ko? So if you're in the area, you can call Dr. Ko's office and their office staff would probably help you with that. The TIF is covered 100% for Medicare and Medicaid, so that's good. But to your point, all of the insurances are different depending if you have a hiatal hernia or not. Right, every patient is different and every insurance company is different. So that's a fair assessment, right? Well, I can't thank you enough. First of all, we've had a lot of questions from Facebook, so thank you, Facebook users, for asking all the questions tonight. Dr. Ko, are there any last comments or anything you want to share with all of our viewers tonight? Whether it's about Gerd or the TIF procedure, or just staying safe here in this pandemic. Is there anything that you'd like to end with?
No, No, I just I'm just so excited to be able to provide this service at this point in my career. You know, I've spent almost 30 years, like I said, and I've been waiting for this kind of procedure to come out, to be able to do this. So, you know, I was supposed to be retiring in a number of years,
And then we brought you to.
and now I'm doing this. And so I'm so excited about this. As I say, no, I'm going to put off my retirement now because I'm just so excited in just so having so much fun doing it, and working with the patients. And I'm just so pleased to provide the service, and the patient coming back, telling me how happy they are, which is great, gives me great joy. So you know, and I can't thank you guys enough for the whole company for developing this kind of tool, which is just an amazing tool to be able to use that.
You, Dr. Ko. Let's answer one last question that we just got that came in, because we forgot to touch on this. Is there any overnight stay after the TIF procedure?
Yes, yes. Usually it's an overnight stay. Right. It's rarely some patients may go home the same day, but it's a typically overnight stay.
Well, with that said, I can't thank you enough for joining us tonight, Dr. Ko. We appreciate all your answers. We got a lot of people saying thank you for all of your answers, and information about Gerd and the TIF procedure tonight. And we appreciate you being on here for our patient, or for the patients and the consumers that are out there suffering from Gerd. So if you are looking for a physician in your area, if you're in the Orange County area, you can see Dr. Ko, but if you're not, you can visit gerdhelp.com. That's our website. And also, obviously, our Facebook page. We have a lot of information on there, and also a physician finder. So you can put in your zip code or your state, and you'll be able to find a physician that is trained in your area. So again, thank you very much, Dr. Ko. We appreciate it.
Having me.
And everybody joining us tonight, thank you very much. And please stay safe out there. We'll catch you next week. Thank you very much.
Be safe.
Bye-bye.